Imagine a severe, life-threatening injury that actually starts right at the bone.
Right, like it literally eats its way outward, just destroying muscle and suffocating living tissue as it goes.
Yeah, it's horrifying. But the crazy thing is, if you were to just look at the surface of the patient's skin, it might look perfectly healthy.
Or maybe, at worst, there's just a slight, unassuming purple bruise, nothing that screams danger.
Exactly. So today we are looking at the hidden algorithm that hospitals use to predict this invisible catastrophic damage before it even happens.
Because, it is one of the most chaotic physiological problems in all of modern medicine.
Welcome to today's deep dive. We're so glad you're joining us.
Yeah, thanks for being here.
We are analyzing a huge stack of clinical documentation, medical history, and nursing protocols to decode something called the Braden Scale.
Right, and our mission today is to uncover this 40-year-old operating system that just runs quietly in the background of almost every single hospital stay.
It's wild. It dictates patient care. It moves billions, literally billions of dollars in healthcare funding. And yet, unless you work in medicine, you probably have absolutely no idea it even exists.
Which is a real shame, honestly, because it really is a masterpiece of predictive risk assessment.
Yeah.
The Braden Scale isn't just some administrative, medical checkbox. It's an attempt to solve that chaotic physiological problem we mentioned using pure logic and observation.
So it's asking basically how vulnerable is this specific body lying in this specific bed right at this exact moment?
Precisely. It's highly specific and localized to that exact point in time.
See, I always assumed that a diagnostic test meant finding a problem that's already there, like an X-ray.
Right, you break a bone, the machine shows you the break.
Yeah, and the doctor just points to it. But what's fascinating about this tool is that it's entirely predictive.
Exactly. It is not diagnosing a wound at all. Fundamentally, the Braden Scale, or to use its full name, the Braden Scale for predicting pressure sore risk, is a screening instrument.
A screening instrument, okay.
Yeah, so it's not looking for what has already happened. It's estimating how likely you are to develop a pressure injury in the near future.
So how does it actually do that?
Well, a nurse evaluates a patient across 6 specific subscales.
Okay, let me make sure I have these right. It's sensory perception, moisture, activity, mobility, nutrition, and friction and shear.
You got it.
Oh.
So the nurse assesses the patient in those 6 areas, assigns a numerical value to each one, and then just sums them up for a total score.
Now, I have to bring up the scoring system itself because, well, it notoriously trips up almost every first-year nursing student.
Oh, constantly.
Right, because the total score ranges from 6 to 23. But in the weird mathematical world of the Braden scale, a lower number actually means a higher risk.
Right, it's an inverted scale. So for the first 5 categories, that's, sensory perception, moisture, activity, mobility, and nutrition, the patient is scored from 1 to 4.
Okay.
And a score of 1 is the absolute worst. It indicates the least favorable condition, and a 4 is the best.
And then friction and shear is scored 1 to 3, right?
Yeah, simply because there is no realistic, no problem at all state when you're just lying in a hospital bed all day.
Okay, that makes sense. So thinking about this, the best analogy I could come up with is like a classic video game health bar.
Oh, I like that.
Yeah, so you want your score as high as possible, up in the 20s, which means your defenses are fully intact.
Right.
But as that number drops down into the low teens or, single digits, your bodily defenses are failing. You're entering the danger zone.
That is a highly accurate way to visualize it, yeah. Most hospitals treat a total score of 18 or below as the threshold for a patient being officially at risk.
Okay, 18 is the magic number.
Usually, yes. Although, if you are in a critical care setting, like an intensive care unit, they might drop that threshold to 16.
Wait, really? Why would they drop it in the ICU?
Well, the rationale is that the entire pool of ICU patients is already so critically ill and immobilized, you kind of have to adjust the baseline. Otherwise, literally everyone is flagged as high risk.
Wow. Okay, that's intense. But before we dig into the history of how this was engineered, we have to talk about what this tool is actually trying to prevent.
Yes, the terminology itself is super important here.
Because it's literally shifted underneath the scale over time.
Okay.
When it was first created, everyone talked about bed sores or pressure ulcers.
Right, those were the common terms for decades.
But then around 2016, the medical community made this massive shift in how they talk about this, didn't they?
They did. The National Pressure Ulcer Advisory Panel, which actually later formally renamed itself to the National Pressure Injury Advisory Panel, changed the official terminology from pressure ulcer to pressure injury.
And when you really look at the pathology, that is a chilling distinction.
It really is.
Because when I hear the word ulcer, I picture a broken open wound right on the surface of the skin.
Like a crater, yeah.
Exactly. But an injury means the tissue damage can happen completely underneath entirely intact skin.
And that gets back to the terrifying pathology you mentioned at the very beginning of our deep dive.
Right.
A deep tissue pressure injury occurs when the tissue near the bone is literally suffocated.
Suffocated, wow.
Yeah, so a nurse could be looking at what appears to be healthy, completely unbroken skin, documenting it as totally fine.
While underneath?
While underneath, the muscle and tissue are actively dying from a lack of blood flow.
That is so scary.
The shift to the word injury is so important because it acknowledges this invisible subsurface spectrum of damage.
Okay, so if an injury can happen invisibly under the skin, how did anyone ever figure out how to measure it?
Well, it took some trial and error. Back in the 1960s, there was something called the Norton scale.
But it seems like it was missing some pretty huge pieces of the clinical puzzle, right?
It was. The Norton scale was developed in the UK in 1962. And, I mean, it was groundbreaking for its time.
Sure.
But by the late 1980s, researchers were realizing it was a bit too thin.
What do you mean by thin?
It didn't explicitly separate out crucial physiological factors,
Yeah.
particularly nutrition, or the actual mechanical forces acting on the body.
Oh, I see.
So in 1987, two researchers, Barbara Braden and Nancy Bergstrom, published a foundational paper to basically replace it.
They basically looked at this messy clinical mystery like, why does patient A get a sore while patient B is totally fine? And they distilled it down to first principles.
Precisely. They broke the physiological premise down into two brilliant, distinct causal pathways.
Okay, bucket number one.
The first pathway is the intensity and duration of pressure. So this is covered by the subscales of sensory perception, mobility, and activity.
So basically asking, can the patient feel discomfort? Or are they just stuck in bed? Can they physically move themselves to relieve the weight?
Exactly. It's the literal physical weight and time pressing down on the body.
Got it. And the second bucket?
The second pathway is tissue tolerance, meaning how well can the patient's skin and underlying tissue actually withstand the physical pressure it's experiencing.
Ah, okay.
This is where moisture, nutrition, and friction and shear come into play. Like, does the patient have the protein reserves to keep their cell walls strong? Is their skin constantly weakened by sweat? Things like that.
Well, let's talk about the timeline of that pressure, because I have to admit, a major misconception I had coming into this.
Let's hear it.
I've always assumed a bed sore is the result of days or maybe even weeks of extreme neglect.
Oh, that is such a common belief.
Right, like you leave someone sitting in a chair for a solid week and eventually they get a sore.
That is one of the most dangerous misconceptions out there, actually.
Really?
Yeah. If a patient is under severe combined risk, meaning, they're deeply sedated, their blood pressure is low, so their tissues aren't getting good oxygenated blood.
Okay.
They're malnourished, and there's moisture present. If all that is happening, tissue necrosis, which is actual cell death, can begin in just a couple of hours.
Wait, 2 hours?
Yes.
That is terrifyingly fast. It completely upends the common sense assumption of how resilient the human body is.
It really does. And if we connect this to the broader picture of hospital operations, this is exactly why turn the patient every 2 hours is the absolute golden rule in nursing protocols worldwide.
Because that physiological window for irreversible cellular damage is just incredibly narrow.
Extremely narrow.
And I want to circle back to the mechanics of that damage, specifically friction and shear. Because understanding how they physically destroy tissue is just wild.
It's gruesome but fascinating.
Like, friction is easy enough to understand. It's the surface of your skin dragging roughly across the hospital sheets, basically a rug burn.
Right, simple surface friction.
But shear is vastly more insidious. Shear is when your skin stays perfectly gripped to the bed sheets, but gravity pulls your heavy skeleton down toward the foot of the bed.
Exactly. And when your skeleton slides down, but your skin stays put, it violently stretches and twists the tiny, delicate blood vessels that connect the bone to the skin.
It essentially just pinches off the blood supply.
It tears and pinches them, completely starving the tissue of oxygen.
What?
So it suffocates the tissue from the inside out long before friction ever actually breaks the surface of the skin.
Man, because that 2-hour window for irreversible damage is so tight, nurses can't just walk into a room and guess who merely looks fragile.
No, absolutely not. Looks can be incredibly deceiving here.
Right, so the clinical documentation provides 3 very distinct examples of how risk wears completely different faces in a hospital. Let's walk through them for you listening, starting with example 1, the expected.
So the expected profile aligns really well with the validation population for the original Braden studies, which focused heavily on nursing home residents.
Okay.
Paint a picture of an elderly patient who has, say, recently had a stroke, suffers from mild dementia, and experiences urinary incontinence.
So they basically fail every single subscale on the Braden scale simultaneously?
Yes, sadly. They lack the mobility to shift their own weight. Their sensory perception is severely dulled by the dementia and the stroke, meaning they might not even feel the pain of the pressure. Moisture is constantly present from incontinence. And, their advanced age likely brings compromised nutrition and fragile skin. It's a tragic, perfect alignment of all the scale's risk variables.
That's the obvious one. We can all picture that. But example 2 is what the sources call the unexpectedly vulnerable.
Yes.
And this is where it gets really relevant for you, the listener, because this could be you after a bad car crash or a severe bout of pneumonia.
Right. Anyone can end up in this category.
You're young, you're healthy, you work out. On paper, your baseline health is fantastic, but now you're in the ICU.
And this is where the Braden scale reveals the hidden danger. That young, healthy patient is now, say, on a mechanical ventilator.
Okay.
To tolerate that breathing tube, they're deeply sedated. Instantly, their sensory perception score collapses to a 1. They cannot feel pain or tell anyone they are uncomfortable.
Oh, wow. And the ventilator means their activity and mobility scores plummet to a 1 as well.
Exactly. Plus, because their body is fighting a massive trauma or infection, they're likely experiencing diaphoresis, which is heavy sweating.
So that ruins their moisture score.
Yep. And because they are essentially dead weight under sedation, every time the nursing staff tries to reposition them to help, it creates immense friction and shearing forces.
So this young, remarkably healthy person suddenly generates a Braden score that is dangerously low.
Very low. It easily drops below that strict ICU threshold of 16.
Which brings us to example 3, the high scorer trap. I found this one fascinating.
This one is so tricky.
This is the ambulatory hip surgery patient. They're awake, they're cognitively intact, and they can physically get up and walk around the room with some help.
Right. They look great on paper.
Their overall score might be a 19 or a 20, which clearly says low risk, but they still develop a massive pressure injury. How does that happen?
Well, because in clinical practice, the pattern of the score matters just as much as the total number.
That pattern, okay.
Let's say this hip surgery patient also happens to have advanced cancer, causing severe malnutrition. And as a side effect of their medications, they have severe postoperative diarrhea.
Which means constant moisture on the skin.
It's exactly
like a student's GPA. Having a 3.0 GPA overall sounds great. You're passing the grade.
Yeah.
But if you have A's in math and science, yet you have an absolute 0 in moisture and nutrition, that single profound failure can just ruin you.
That's the perfect way to look at it, honestly.
Right.
You can have perfect mobility, but if your tissue is starved of protein and constantly macerated by moisture, it is totally defenseless.
Let's actually define macerated for a second, because that's a very clinical term, but we've all experienced it.
Oh, sure.
It's like when you stay in the bathtub way too long and your skin gets all white and prune-like, it becomes incredibly soft and fragile.
Exactly. That's maceration. When skin is macerated from prolonged exposure to moisture, its tensile strength just evaporates.
Wow.
It simply cannot tolerate even normal everyday pressure without tearing or breaking down. So a high total score can completely mask a fatal weakness in one specific area.
But wait, if this scale can generate these weird traps and false alarms, why is every nurse in the country forced to fill it out every single shift?
Well, that brings us to the year 2008.
Right, when the government stepped in and tied this clinical tool directly to hospital bank accounts.
Yes, in 2008, the Centers for Medicare and Medicaid Services, or CMS, instituted a major policy shift. They designated hospital-acquired pressure injuries as never events.
Meaning the government decided this should absolutely never happen under a hospital's watch.
Precisely. They deemed them reasonably preventable conditions.
Okay.
And the financial hammer came down. Hospitals would no longer receive any additional Medicare reimbursement for the cost of treating a pressure injury if that injury developed during the hospital stay.
So overnight, this clinical tool mutated.
It really did.
It was no longer just about nursing care. It became a mandatory piece of legal and financial risk management.
Absolutely. The hospital desperately needs that Braden score documented on the chart every single shift.
Just to prove to the government, hey, we identified the risk and we did everything right, so they don't have to eat the massive cost of the treatment.
Exactly. It
Yeah.
raised the institutional stakes astronomically. And unfortunately, that administrative burden has led to a well-documented failure mode known as assessment fatigue.
Or the checkbox problem.
Yes. When nurses are under extreme time pressure, this vital clinical evaluation can devolve into just a rote administrative task. Nurses will sometimes just pull up the computer and copy forward the previous shift's score.
Which is so dangerous. Copying a previous shift score is like driving a car down the highway while only looking at a photograph of the road taken 5 miles ago.
That's a great analogy.
You are guaranteed to crash. The whole point of the tool is to catch real-time changes in risk.
Exactly. A patient's condition is incredibly dynamic. If they spike a fever at 2 a.m. and start sweating profusely, or their blood pressure suddenly drops, their risk profile changes instantly.
Right.
A copied, stale score completely masks that life danger.
And because of those high financial stakes, hospitals tend to err on the side of extreme caution, which exposes one of the main flaws of the Braden scale. It casts way too wide a net.
Yeah, in clinical terms, we say the tool has high sensitivity but low specificity.
Meaning it's like a hyperactive smoke detector.
Yes.
It will definitely catch an actual fire, but it also goes off every single time you try to make toast.
That's exactly it. It is very good at catching almost everyone who will eventually develop a pressure injury.
Wow.
But it flags a massive number of patients as at risk who were never actually going to develop a bed sore in the first place.
So you end up with nurses deploying all this intensive preventive labor hauling in specialty mattresses, strictly enforcing 2-hour turning protocols, applying expensive barrier creams on patients who don't actually need it.
Right. It is a defensible trade-off for a screening tool. I mean, in medicine, you'd generally rather over-prepare than under-prepare, but it contributes heavily to that assessment fatigue and wasted resources.
For sure.
It's also why the medical field is constantly tweaking the tool. For
Mhm.
instance, when you look at pediatric care, you realize kids have completely different skin physiology.
Right, they're not just tiny adults.
Exactly. Their pressure injuries often come from medical devices like breathing tubes pressing on their cheek or tight casts, rather than just the gravity of their body weight.
Mm.
So they developed the Braden Q specifically for pediatrics.
And over in Europe, they largely prefer something called the Waterlow scale, right?
Yes. The Waterlow scale factors in additional variables like body build, a weight for height ratio, and the effects of specific medications.
Oh, interesting.
It represents a slightly different clinical philosophy about which bodily variables are actually the most predictive of tissue breakdown.
So stripping away all this hospital bureaucracy and financial maneuvering, let's clear up some of the most dangerous misconceptions for you, the listener.
Good idea.
Because odds are you are going to encounter this tool at some point in your life. Let's do a rapid-fire misconception check.
I'm ready.
First, if a patient gets a dangerously low score, does that mean they are absolutely doomed to get a pressure injury?
No. It is a probability, not a prophecy. A low score simply triggers urgent preventive interventions. It doesn't guarantee a bad outcome if the care is effective.
Okay, what about the exact opposite? A high favorable score means we can just relax and ignore them, right? They're totally safe.
Definitely not. As we discussed, risk is highly dynamic. A patient can deteriorate rapidly in just a few hours after a surgery or a new infection.
Right.
That is exactly why constant real-time reassessment is mandatory.
Last one. With all this focus on algorithms and scores, can a hospital just use this math instead of having a nurse physically check the patient's skin?
Absolutely not. The scale's own creators, Braden and Bergstrom, stress that it merely supplements clinical judgment. It can never, ever replace a direct visual and tactile assessment by a trained professional.
So what does this all mean for you listening right now? Why should you care about a 40-year-old nursing algorithm?
Well, pressure injuries are agonizingly painful, they are incredibly costly to treat, and they disproportionately affect the elderly.
Which means, at some point, you might be sitting at a loved one's bedside in a hospital room, and a nurse is going to walk in and ask, "How is their appetite today? Can you feel this when I touch your heel? All right, let's get you rolled over."
And when you see that happening, you are actually watching this algorithm quietly running in the physical world.
Yeah.
The nurse is calculating variables, assessing tissue tolerance, and trying to save your family member from an invisible, completely preventable injury.
It's incredible when you realize the invisible math happening all around us. Which brings us to the future. We talked about how the Braden scale's biggest flaw is triggering all those false alarms, which exhausts the nursing staff. But what happens next?
This raises a really important question about the limits of human assessment. Will this 40-year-old manual questionnaire eventually be replaced entirely?
Oh, like by AI or something?
Sort of. We are rapidly moving toward an era of smart support surfaces. So, hospital beds equipped with thousands of microsensors.
Oh, wow. So instead of a nurse coming in and manually asking questions every 12 hours, the bed itself is continuously monitoring the real-time physical pressure.
Exactly. Imagine a bed that doesn't just measure a patient's weight, but calculates interface pressure and tissue tolerance dynamically, second by second.
That's mind-blowing.
It really is. It could bypass human assessment fatigue entirely. It could send an alert to the nurse's station at the exact moment a specific patient's tissue is reaching its physiological breaking point.
Completely eliminating the guesswork of the 2-hour window.
Exactly.
So we started this deep dive talking about how diagnosing tissue risk was like trying to read a shadow, a murky, invisible guess. But maybe, just maybe, technology is going to give us that clean, high-definition X-ray vision after all.
It's definitely on the horizon.
Something for you to ponder the next time you look at a standard hospital bed. Thank you so much for joining us on this deep dive today.
It's been great.
Keep your eyes open for the hidden systems running the world around you, and we will catch you next time.